Here. Thank you. And we're going to talk about, I know the schedule says medical child abuse, but I briefly wanted to just go over vulnerable child syndrome as well. That's often something that is on the differential that you have to consider. So we're going to start there first. As you guys know, just kind of jump in and ask questions as they come. You don't have to hold them all to the end. So first, what is vulnerable child syndrome? So it's first described, coined the term in 1964. It's basically where you have a physically healthy child who is viewed by the parent as being at increased risk for behavioral problems, physical ailments, developmental delays, things of that nature. And it occurs when the child's primary care provider and the parent have discordant perceptions of the child's health. The prevalence used to be about 10%, but with the NICU advances that have been coming out and more and more premature infants coming out of the NICU, there's been an increase in vulnerable child syndrome, and we'll kind of talk about why that is here in a minute. So what are some of the red flags for pediatricians? So if you have that one parent that has frequent calls or visits to a clinic or to a minor care, urgent care, or to emergency department, they have excessive concerns over minor medical problems, such as the otitis media, that then the parents have concerns will see to the meninges and they'll get meningitis. Or they'll have a child that has some viral symptoms, but then the parents are concerned that there'll be early signs for pneumonia or some other thing that's going on. And then the parents are seeking care from multiple sources due to the parents' genuine concern that the child has a problem, and they're not being reassured by the pediatrician. So they're going to different people trying to get that reassurance. So what are some of the consequences that come from the vulnerable child? The parent often exhibits anxiety when separated from the child. And so sometimes you'll have delayed start of school for the child because the mother feels like they're the only ones that can take care of this child's ailment and they have to be around. And then therefore it inhibits the child developing proper socializing skills. And then also the parents tend to have problems setting proper limits on this child because they think they're so fragile. And so they can become what we call too permissive. So they'll give in to every request. So for example, if you have a child that maybe had a milk protein allergy as an infant and the parents had to put them on a special formula. Now this child is like 4, 5, 6, and the parents are letting the child eat whatever they want because they had this weird GI thing when they were younger. And the parents have concern that they're a picky eater. So I let them eat whatever they want because they had this diagnosis way back when, and the parent is just kind of carrying that on until now. And so they have these permissive behaviors with the child. So what are some of the responses that you may hear when you talk to your parents of children with vulnerable child syndrome? So you can say to the parents, what are your concerns? The parents may say, my baby seems a little bit less healthier than the other kids her age, or whenever something goes around at school or daycare, my kid always catches it. They catch everything. I think they have a decreased immune response or something. Or they'll say, my child is really clumsy. They seem to have more accidents and injuries than other kids do. Or I keep them indoors because they've got allergies that lead to asthma flares. Or sometimes I'll worry that my child may die. And so sometimes those concerns seem like they're over the top, very extreme, and it can kind of teeter that line between, is this vulnerable child syndrome or is this a medical child abuse situation? So what are some of the risk factors for vulnerable child syndrome? So on the maternal side, if a woman has had multiple miscarriages, sometimes that heightens their anxiety about the health of their child. If they dealt with some infertility and finally were able to conceive a child, and then they have heightened concerns about that child's health. If the mom had any type of illness during her pregnancy, she'll wonder if she did something during that pregnancy that can affect the child. OCD can be a risk factor as well, and loss of a previous child, particularly if the mother lost a child, say at age 18 months, and then the second child comes along, and that's the vulnerable child case that you're looking at. as that child approaches that 18-month mark, which is the age that the mother had a previous loss, then sometimes the vulnerable child syndrome red flags will rev up around that time as well. So what are some of the risk factors? We kind of touched on it earlier about prematurity and low birth weight infants with the number of NICU graduates rising with the interventions of NICU medicine, then you'll have a rise in some of those vulnerable child cases. If the child was hospitalized in infancy, so your brewery admissions and things of that nature, sometimes that will be the index for a vulnerable child case. If they have feeding problems in infancy, we talked about the changing in formula sometimes can cause that concern for the parents. Positive newborn screens. So if someone has like a trait, sickle cell trait on the newborn screen, or say if the child had an innocent murmur at some point, sometimes those things will be the index for a vulnerable child syndrome, or if it's a firstborn as well. And sometimes the initial event that is the jumping off point for the health concerns doesn't have to occur in infancy. So it can be a child that maybe had febrile seizures, or maybe had their first wheeze with a new onset asthma diagnosis, or a minor head injury, or gastroenteritis, or otitis media. Those things can also be the catalyst for vulnerable child syndrome. So some other familiar risk factors are parental anxiety or depression, parental low self-esteem, loss of a close family member as a child. So that sometimes can have concerns for inherited conditions. So if the parent had a parent themselves or a sibling that died from a congenital concern, then they're worried that their child has inherited the same. The parental loss of a close family member or a friend can cause a risk factor, or a lack of social support. So things that are not risk factors, socioeconomic status, parental education level, and sex of the child are not considered risk factors for vulnerable child syndrome. So this next slide just kind of compares the two of a vulnerable child and overprotection. Those are also very different things. So when you have your vulnerable child syndrome, like we mentioned before, they can have excessive medical visits, and the visits stem from a medical issue the child had in the past. And it can result in the child with behavioral issues, like we mentioned, with the being too permissive from the parents. On the flip side, you've got your overprotection. Those are not associated with excessive visits, and they usually stem from a psychiatric issue with the parent, and the child can also then have a psychiatric or developmental issue because of that. So how do you manage your vulnerable child cases? So first you want to recognize it and document it. Then you want to allow for additional time for these patients because their parents need a lot of reassuring. So you need to pay close attention to clues that things that can trigger the parents' onset of their anxiety. So you want to discuss the normal exam findings and just really hammer in how those things are not concerning for whatever is causing the parent to bring up all these excessive diagnoses or signs and symptoms that they're coming to you with. And then you want to discuss a game plan, because you can be guaranteed that you can do all the reassuring you feel like you can in the office. And when the parent leaves and the child has one minor sign or symptom, then they're going to come right back to you. So you want to give them a game plan. So you could say, for example, okay, I know you have concerns that your child has a fever. You can give them Tylenol, it'll be okay. But let's go over a plan on if they have a fever 2 hours later. You want to talk about alternating that Tylenol, ibuprofen. Give them a plan, because if you just tell them take Tylenol with the fever and the fever comes back 2 to 3 hours later, they're going to call you again and say, my child has another fever. They're going to have a febrile seizure. What do I do? What do I do? So with these parents, you really want to give them a solid game plan. You also want to think carefully before you order any tests or do procedures or order labs for these patients, because that can feed into the parents' concern, because in their minds, it may be, well, this is nothing I need to worry about. Why are you doing all this extra stuff? But the tests that are necessary, make sure you're explaining the results clearly to the caregivers. You can also consult social work and have them meet with the family to help with some support services. And you also want to discuss appropriate age limits and boundaries with the children. So we're going to jump to medical child abuse. It used to be called Munchausen syndrome by proxy, but that name changed because Munchausen syndrome by proxy had the connotation that something was wrong with the parent, and it took the focus away from the child. So when we changed the term to medical child abuse, it focuses on the care of the child, the medical treatment that they're getting, and it affirms the diagnosis of abuse. So what's the definition of medical child abuse? So it's a child experiencing unnecessary and harmful or potentially harmful medical care at the instigation of a caretaker. So are we partly to blame as medical providers? Is this diagnosis resolved by using evidence-based medicine? Can it be worsened by using the patient satisfaction scales that we're being bombarded with? So medical child abuse is just as important as physical abuse and sexual abuse. The severity can range from mild to severe. It is not an illness, but it can result in illness in a child. And the perpetrators of abuse can have many different motivations. But the bottom line is the medical care system is the instrument of the abuse. We are not the perpetrators of it, but we are used as the instrument of abuse. So there have been a lot of studies that have looked at medical child abuse, and there was research that was conducted at Hasbro Children's Hospital in Rhode Island, and they looked at cases that were referred for medical child abuse. And out of the 115 cases that were referred, 75% were determined to be cases of medical child abuse. 74% received excessive, unnecessary medical care, and 26% never even had an illness documented. So in that study, a lot of the things that were documented were just signs and symptoms, but no formal diagnosis was ever given. So when you look at these medical child abuse cases in that same study, 90% of the time, the caretaker exaggerated a child's symptoms. 74% of the time that the caretaker just totally made up the symptoms. So in that 90%, the child may have had a fever of 100.9, but then the parents come in and ratchet it up by exaggerating it, saying it's 102, 103. But in that 74%, the child did not have any signs or symptoms at all, and it was fabricated. But then there's also a very small subset of cases in that study where the caretaker induced the child's illness. So what does that mean? So it was a parent that was putting, there was a parent that was putting feces on a central line, so causing blood cultures to be positive and causing the child to be septic. There's also one where the parent was putting insulin in a child's line and causing them to be hypoglycemic, so inducing an illness. When we talk about fabricating a child's illness, it could be that there's normal breathing, but then the parent comes in and says that the child is apneic. They were apneic at home, and so I have concerns. A common example of exaggerated symptoms would be maybe a child that has normal spitting up when the parents come in and they report projectile vomiting. So what are some of the types of the unnecessary care that's received by the medical child abuse cases? So the majority of them are just excessive visits to the medical team. Then you can have some non-invasive tests that are done. That can be your imaging studies, or minimally invasive tests is also a large percentage. Then you can have medications that are prescribed, invasive tests or minor surgeries that can be used in these cases as well as an instrument of abuse. And then you also have your major surgeries that can be implemented. So like the G-tube placements or exploratory laparoscopic procedures, things of that nature. So how is medical child abuse different from vulnerable child syndrome? So as we kind of already went through the things on the left side of this slide, your vulnerable child syndrome tends to affect only one child at a time, whereas sorry, only one child within the family, because that's the index kid that had that medical issue way back when, and the parent is still kind of harping on that. Versus medical child abuse, it's usually only affecting one child at a time. And what we've often seen in some of our really severe cases where there's been a fatality is that once that child dies, then the parents start exaggerating symptoms in another child, and they start coming in for multiple visits and things of that nature. On the vulnerable child syndrome side, you have a child that has a normal pediatric illness that's over exaggerated. But on the medical child abuse side, sometimes you'll have unusual complaints or life-threatening events, or sometimes the parents will say, doctors at quote unquote top-notch hospital, so they've never seen anything like what my child has before. So I'm pretty sure you're not going to be able to figure it out. So when you're trying to reassure the parents that this is not a thing, they'll tell you, oh, my child has this rare thing, or it's only picked up by continuous EEG, or this really expensive lab test, things of that nature. On the vulnerable child syndrome side, children usually do not have the rare conditions that are difficult to diagnose. However, on the other side, like we just mentioned on the medical child abuse, they usually have that 1 in a trillion diagnosis that most doctors don't see. So how do you manage the vulnerable child versus the medical child abuse cases? So we kind of talked about how reassuring is important on the vulnerable child syndrome side, but on the medical child abuse side, you don't want to ignore on your differential diagnosis. Make sure you include it. Be objective. Don't go with your gut feelings on these. You have to write down what the parents have said, what medications they're bringing in, what procedures they've had done that's been documented, things of that nature. And you want to consult your child abuse provider early on your medical child abuse cases so that we can inform the appropriate investigators. And here's another reason why you want to get us involved early on. It takes a lot of time to organize these cases. And so if you've got a kid that's been in the hospital for a week, and then you consult us right before discharge and ask us to come in and work with the family and work with investigators because we have concern for medical child abuse, that child's probably going to end up staying in the hospital a few more days while we get everything organized and coordinated with DSS, law enforcement if necessary, social work. We have to have a care team meeting, all those things that come into play. I'm going to show you an example of a pretty involved spreadsheet, and I don't know how well this is showing up on your screen because it looks really small on mine, but this was a medical child abuse record review spreadsheet that I had to do back when I was in fellowship. And so basically we documented all the blue cells are the inpatient visits. The purple cells were when the child was seen by a specialist. Orange cells was when the child was seen in the emergency department. Green is the PCP, and the white cell was all ancillary therapies. And I believe this document ended up being 54 pages because we had to document the date, where the child was seen, the reason for the visit, the exam findings or the labs or the imaging studies that were done, what the plan was, and what the concern was, because you really have to document all of this if you're going to take it to DSS, law enforcement, or a judge and say, look at all these unnecessary things that this family has had done to this child. So you want to get all the providers on the same page. So we often get a care conference early on, and we can help facilitate that. So if you consult child abuse, we'll talk to neurology, GI, surgery, primary care doctors, social work, and bring them all together and do a care conference. And then what we do is, amongst us providers, we come into agreement on what a contract should be for this patient. And then we go to the family afterwards and say, we've had this meeting with all these specialists. This is what we feel like is the best plan of action for your child. Let me know what your concerns are. We'll talk about it, and the family will sign it. And then this information gets disseminated to the caregiver, so they get a copy. The patient, if it's an old enough child, gets a copy, and the medical providers have that copy, so that the next time something comes up and the child presents in the PCP's office or the emergency room or urgent care, we can refer to that contract and see how the care deviated from that. But prior to being discharged, once they're in the hospital, you want to get rid of the most invasive or risky interventions first. So if you've got lines, G-tubes, or meds, you want to go ahead and take those off in a stepwise fashion. You don't want to stop everything at once, because then if the child does have some type of decline, you don't know exactly what it is that was withdrawn that caused that. So you want to take it away in a stepwise process. Then you want to find some mental health services for the parent and the child. And you want to work with the outside providers, because again, the child may not always present to the hospital. They may present to other community providers. And so I know I kind of went through that fast, but there really isn't a whole lot of clinical investigating that you have to do for these cases. It's a lot of social work, hand holding, and kind of giving the parents information that empower them on how they can care for their child and what's necessary and what's not, and a lot of documentation. So it's just a Venn diagram that I really, really love. So I'm sharing it with you all, but I wanted to open up for any questions that you guys have had. And I'm also interested in knowing how many of you all have actually cared for a case where you feel like the child had a diagnosis of medical child abuse, and what some of the presenting factors were and what the outcome was. Has anyone had any one of those in the last year?
I have a question, if that's okay.
Oh, of course. What's up?
I apologize if I missed this in the beginning. With medical child abuse, most of the time, does the child also believe that they have the illness?
Yes, yes. Most of the time they do. Especially, it also depends on how early in that child's life the parent kind of started implementing all these interventions and procedures. So the younger that it was started, the more buy-in the child has at that point. Because also you want to think about, a child looks at their parent as someone that's going to protect them and as a caregiver. And so they would find it very hard to believe that their parent would be doing something to them unnecessarily. And so they're thinking that their parent has their best interests at heart. And so they've really bought into, I've got this medical diagnosis. And that's why you really want to make sure you bring in the mental health resources for the child as well as the parent. One thing that's really interesting though with these cases is that what DSS will often do is do a trial separation between the child and the parent, and put the child in foster care and document, if it's failure to thrive, where the child is gaining weight. If the parents are saying this kid's having 20 seizures a day and they're on all the seizure medicine, and then you've taken them off in the hospital, you put the child in foster care, the child hasn't had a single seizure in 3 months. And so you'll have a lot of that separation too. But the concern is, once the child is healthy, if you give them back to the parent, they become sick again. So what has to happen is the parent has to recognize that things that they were encouraging and pushing the medical community to do was wrong, and what they were doing harmed the child. So until that parent can actually recognize and accept that what they were doing harmed the child, reunification is really, really hard with these cases, and most times they don't get reunified.
Thank you.
You're welcome. Any other questions? All right, you guys have been great. Thank you for listening to my short presentation.
Thanks, Dr. Young.
You're welcome.